Good afternoon, everyone. Welcome to Oncology Insights, the fourth series in our webinar series. Well, we spoke about basics of oncology. We spoke about pediatric hematology and pediatric oncology. And well, the last one was on breast mass, evaluation of a breast mass from a younger woman to an older woman, from a male who has chest wall lesion to, of course, a woman who has a breast lesion. And now this time is a focus on lung mass. And this is extremely important to all of us as practicing physicians, even as a general population and a caregiver, to be well informed that any untreated lung condition could actually be a cancer hidden inside which we would have missed. And so recognizing the subtle signs and symptoms, recognizing with a situation where we need more workup, sometimes even untreated tuberculosis, occupational hazard with pictures like pulmonary fibrosis, chronic obstructive pulmonary disease in a smoker, all warrant investigation and finding out whether it's not related to cancer. So today we'll be talking about journey of a lung mass, right from what we know in terms of epidemiology, its prevalence, to its diagnosis and treatment. And I'm Dr. Neeti Krishna Raizada, and I work as a medical oncologist and a hemato-oncologist at Fortis Group of Hospitals in Bangalore. We have participants from all over the country, and in all our webinars, we have been starting with announcing the winners of the previous quiz. Last time in the Breast Mass Oncology Insights, we had almost 700 people who had registered for the webinar. We had almost 500 people who participated in the quiz. And here are the winners. Well, the first winner gets 12,000 and the second winner gets 8,000 rupees as a UPI transfer. We'll do it all at one time. Each one of you who participates gets a certificate of participation, and the winners get a certificate of winning the quiz as well. So these are the winners of the third webinar on breast mass. Well, the first prize is Dr. Charita. She's from MGM Hospitals in Warangal. Congratulations, Dr. Charita. Dr. Soni KP is from Medical College Hospital in Ernakulam, who's the first prize holder. The second prize goes to Dr. Tejaswini. She's from Shiv Ganga Hospitals in Belgaum. And Afifa Sultan, who's from Sapkiri Institute of Medical Science in Bangalore. Now, first prize and second prize is shared by our winners. So probably the prize money will be split by two people. And I start with my topic today. Well, as I said, lung cancer, knowing about it is extremely important because it's one of the most lethal and one of the most common cause of cancer worldwide. What exactly is cancer? Any uncontrolled growth of cell in any part of the body, a rapid multiplication, uncontrolled multiplication with collection of mutations in any part of the body is known as cancer. And when it happens in a lung mass, in a lung tissue, primarily organ arising from a lung mass or a lung tissue, it's known as lung cancer. Talking about the global data, well, we talk about worldwide incidence, that is how many patients are diagnosed each year. Breast cancer happens to be the most common cancer, but the second most common cancer, when we put both gender combined, is lung cancer. We have almost 2.4 million new cases of lung cancer diagnosed each year globally. But the sad figure is that unlike breast cancer, the most common cause of cancer-related death is lung cancer. Almost 1.8 million of these actually die of lung cancer. With 2.4 million diagnoses, almost 1.8 million die each year of lung cancer. In India also, our numbers are kind of not reassuring. India has fourth common cause of cancer as lung cancer, with almost 87,000 cases diagnosed each year. Now, this may not be actually a true reflection of incidence in our country, because quite a few lung cancer gets unnoticed, diagnosed late, and possibly even not come to the hospital at all. So does not add to registry numbers. So our assumption is the numbers are pretty larger than what is reflected here. And that is what we see as clinicians in our oncology practice on a day-to-day basis, where lung cancer seems to be a very high cancer. Now, when we talk about the death rate, almost 20% of all cancer related death is only because of lung cancer. So imagine the magnitude of death of cancer related death happening because of lung cancer. Every minute, 3 patients die of lung cancer. And most of them, yes, are related to tobacco, which seems to be the most common cause of not just lung cancer, but several other cancers, which happen in our country as well, including lip and oral cavity cancer, including stomach cancer, pancreas cancer, and several others. So, when we talk about the distribution, most often lung cancer would actually present with a lung mass in the upper airway or the upper regions of the lung. There are several reasons why it happens like this, but talking about other things, why and what actually causes lung cancer, I will like to talk about certain myths and what exactly is the reality. So, well, the most common myth we all know is that only people who smoke get lung cancer. Well, the answer, of course, is no, because yes, 80% of lung cancer is associated with smokers, but there's a substantial population, 15 to 20%, who have never smoked. Not just smoked, they have never been exposed to secondhand smoke as well. But when we talk about smoking, not just cigarette, but BD smoking, pipe smoking, cigar, hookah, secondhand smoke, which means that any other family member in your house or your close contact is actually smoking and exposing you to cigarette. And of course, recreational drugs, including marijuana and cocaine, can cause cancer. And this is what all of us, even youngsters, need to realize. Not just smoking, but even recreational drugs can cause cancer. Most common cause, yes, smoking, but then radiation exposure. This radiation could be outdoor radiation or sometimes even radon gas, environmental toxin. Environmental toxin again could be outdoor pollution, but also indoor pollution. Could be a woman who constantly sits in front of a chula or smoke because of emitted daily cooking methods. Even our incense sticks, which are some people are constantly exposed to, occupational exposure, which could be related to asbestos, it could be coal dust, or it could be consumption combustion vapors. All these also cause occupational exposure and can cause lung cancer. And pre-existing pulmonary diseases, it could be chronic obstructive pulmonary disease like emphysema or chronic bronchitis, it could be long-standing pulmonary fibrosis, and certain other diseases as well. Even scar cancers, which happen with tuberculosis scars or some fungal infections which pre-existed and now cause cancer. So these are the other causes of lung cancer. And this is probably the most interesting slide which I found on the net, and I thought all of us should know about it. That if we look at the dynamics of population and the distribution of air pollution in our country, of course, Central India, North India is exposed mostly to significant levels of air pollution, and less in at least in Karnataka and South states, including Kerala. There's less exposure to air pollution. But when you look at the average for the entire country, all of us on an average smoke at least 8 cigarettes per day just on account of the air pollution. Now, what are the some other myths? That only men get lung cancer and only older men get lung cancer. Well, this is again, as it's said in the name itself, it's a myth, not a reality. We see that yes, younger women now who are non-smokers also get lung cancer. There are various factors attributed, including genetic factors, and I mentioned indoor pollution as well, are some of the factors. But younger women with lung masses also should be worked up for lung cancer. Well, only elderlies get lung cancer. Again, the answer is no. Well, age and ageism is, yes, the most important cause of any cancer, including lung cancer, but younger individuals also get lung cancer. We have seen patients in their 20s, 30s, and 40s getting lung cancer. So, yes, it sadly can happen in younger individuals as well. Well, most common symptom is cough, and a person who does not have cough may not have lung cancer. Again, it is a myth. And when we look at the symptoms, what can actually cause or maybe suspicion for lung cancer, the most common is, yes, persistent long-standing cough, but then it could be shortness of breath, it could be unexplained tiredness, coughing of blood from sputum, it could be unexplained weight loss, which is unintentional weight loss. It could be pleuritic chest pain, which could be localized in one part of the chest, and all could be symptoms of lung cancer. But there could be another symptom set of symptoms which could not be related to the primary of the lung, but it could be metastatic disease. A person who presents with back pain could actually have a mass in the spinal cord, which on workup can actually be a metastatic lung cancer. So it was in the lung, but now it is in the spinal cord. You could do an ultrasound and find liver masses. And when you do biopsy of the liver mass, you find out it had actually arisen in the lung, but now in the liver. So metastatic disease can also have its presentation. What can you actually do to prevent lung cancer? First is recognize what could be your possible etiology. You please, if possible, quit smoking. Also reduce secondhand smoking in your environment. If there are people who are smoking, there should be a obviously there should be a warning. Most of the places, most of the public places actually avoid public smoking, and there are some restricted areas of smoking. So actually, all of us should try and comply to those guidelines. Healthy diet has a very important role. Again, not just in lung cancer, but in all the cancers. Diet which is rich in fruits and vegetables. You can avoid red meat if it is feasible. Lifestyle which actually makes you have more fresh air, including some breathing exercises, and avoid toxins and chemicals, especially in your workplace. What are some other myths which we should focus on? Well, lung cancer only affects lung. The again answer is no. Often, I mean, very often, almost 60% of patients will present with metastatic disease. And most often, it will be cancer which is spread to not just the lung, but gone to the bone. It could be in the liver, adrenals, and sometimes even in brain. So that's the importance of staging scan or a staging workup. Well, all cancers, all lung cancer are not the same, and every subtype of lung cancer is treated differently. When we talk about broader subtypes, two large broader subtypes are non-small cell lung cancer, and the smaller subtype is small cell lung cancer. So almost 80% of all lung cancers are non-small cell lung cancer, which could be adenocarcinoma or which could be squamous cell carcinoma. The other subtype is small cell lung cancer, which has a very different presentation but is also associated with smokers. The way we treat is also very different. The way we treat any lung cancer first depends on the subtype, and secondly depends on the stage. And now we also talk about molecular characteristics of each cancer. So when we are talking about early stage cancer, what we mean is it is localized only to the lung. And when it is localized to one organ, we try to give local therapy. And that local therapy could either be radiation or it could be surgery, along with systemic therapy, so that it doesn't spread to other organs, which is chemotherapy or biologic therapy. Now, when we talk about locally advanced stage, it means it is in the lung but has spread to the lymph nodes. This is typically called as locally advanced stage, where again there is a role of local therapy, which could be radiation, and of course, a very important role of systemic therapy, which could be chemotherapy or immunotherapy or biological agents, which are targeted drugs or tablets, which are given to individuals. So this is locally advanced stage. And what exactly is advanced stage? When there's an organ which is involved, like lung or any other organ, which is called as the primary cancer, but spread to some other organ. And in this picture, we see that the patient has lung cancer, which is spread to the liver. And when it is spread to the liver, it's technically called as a stage 4 cancer. It could be bone or it could be brain. And in this, the primary or the backbone of treatment is systemic therapy, which could be immunotherapy, chemotherapy, or targeted drugs. Survival typically depends on the stage and typically depends on actionable mutations. So this is a very typical journey of a patient with lung mass from diagnosis to treatment. So a patient typically comes to our clinic and complains of a certain symptoms. It could be cough, chest pain, bringing out blood, and we take a detailed medical history along with past history, family history, any risk of occupational exposure. You have any habits which could be causing certain type of cancer. We do a good physical examination, including looking at the neck notes, looking at certain factors like clubbing, anemia, whether there's any sign of chronic obstructive pulmonary disease, whether there's a sign of lung mass, and a sign of metastatic disease. Once we have established that what things need to be targeted, typically we start doing a chest X-ray. If there's a suspicious mass, we do a CT or a PET scan. And based on the findings, we decide which is the most appropriate place to do a biopsy. That biopsy could be done by either a bronchoscopy, which is like a endoscopy of the bronchus. You put a tube inside your bronchus and find out where's the tumor by either an endoscopic ultrasound, or if it is intrabronchial growth, take a biopsy from there, or we do a biopsy from a CT guided lesion. So if there's a peripheral lesion, a CT guided biopsies are performed. When biopsy is done, it tells us what is the subtype of tumor, whether it's a non-small cell or a small cell tumor. And on that, we put certain immunohistochemistry markers, which tells us the protein expression of this to classify it correctly. And if we have enough tissue, we send it for molecular subtyping to find out if there's a molecularly targeted drug, which makes us treat the disease much better. And this is the stages I spoke about, stage 1 to stage 4. And this is typically stage 1 to stage 4 is what we do in non-small cell lung cancer. But small cell lung cancer is broadly classified as limited stage or extensive stage based on whether local therapy like radiation can be offered to it or not. Now, most of this will be subclassified and treated based on certain specific markers known as biomarkers. The biomarker testing is often done with tissue analysis, looking for specific biomarkers. But if biomarkers are not tested on tissue because of poor availability of tissue, because lung biopsies are technically very difficult and only very small tissue is obtained, which probably gets exhausted in initially assessing and making slides, we try to send blood samples known as blood biopsies or liquid biopsies to find out if there are some specific markers which are expressed. When we look at Asian subset or when we look at Indian subset, almost 50% of such patients, from 30 to 50%, will only have EGFR expression. And all these subset who have EGFR expression will have an anti-EGFR tyrosine kinase inhibitor, which is given as treatment, which makes our subset respond extremely well to treatment. Other biomarkers include ALK, ROS, NTRK, and MET-RET, and several others, which your clinician will analyze at the time of diagnosis and decide what is the first line therapy or subsequent therapy which they would want to offer. Again, we do testing for immunotherapy as well to decide whether immunotherapy will work on such patients or not. So the next journey is multiple treatment options based on biomarker availability. And these are certain treatments which evolved way back in the 18th century, starting from surgery, which became larger and larger. And then we moved in the early 1900s to focus surgery. In the early parts of 1900, we spoke about radiation, went to chemotherapy and then chemotherapy combinations. And now we talk more and more about targeted therapies plus chemotherapies, next generation targeted therapies, which could be antibody drug conjugates and certain other bispecifics as well. And of course, incorporating it in various proportions to immunotherapy. So this is the summary of what we do. Find out what is the histological subtype. We find out what is the biomarker which is expressed in such patients. Find out the stage, whether they have brain metastasis or not. What is the tumor burden? What is the extent of disease? How symptomatic is the patient? And how urgent is the treatment option? And based on the fitness, because often patients are older patients, whether they have hypertension or diabetes, which is controlled or not controlled, what is the fitness of the individual? And of course, what is patient's wish? Whether they want to come regularly or they want a treatment as tablet option, what is the physician's preference and what is the need of the institute's, how the institute has been managing thoracic oncology or lung cancer patients and how developed that institute is in terms of its treatment, what is the social support network of the patient, and of course, if there are any clinical trials available for the patient. Now, quickly talking about screening. Now, as I had mentioned before, screening is done for healthy individuals who don't have any symptoms. But lung cancer screening is specially done for high-risk individuals. And what is high-risk individual for lung cancer screening? Well, high-risk individuals for lung cancer screening are patients who are 50-year and older, who are either current smokers or who have quit smoking in the past 15 years, but have history of 20 pack years of smoking. So it's a significant smoking history in the past few years. The individual has to be between 50 and 80 years of age and should be either currently smoking or should have recently quit smoking, that is in the past 15 years. Now, what do we do in screening? Well, we do once a year high resolution CT scan for such patients. So a low dose CT scan of chest done once a year along with smoking cessation counseling is done for such individual once a year, and we look for suspicious lesions which require assessment right now or needs close interval follow-up. Screening is a safe and easy method, often accurate if it is done in right time. And yes, it is low cost. It's lesser cost than actually thinking of treatment related solution. So if you catch a disease early, then the results are better. And of course, cost risk benefit is also much superior. So again, the next myth is once I have lung cancer and it spreads, it becomes untreatable. Well, the answer is no. We have newer drugs, we have newer technologies, and we have safer, better options to treat you better, to prolong your survival, and in a safe way so your quality of life is well preserved. With this, I quickly summarize. Well, lung cancer is a global health issue with one of the being the deadliest cancer available actually, with 1 in 5 cancer related deaths is only because of lung cancer. Smoking, yes, is the most common cause, but there are non-specific symptoms and cough is just one of them. So if you have chronic non-specific symptoms, visit a doctor. Look for your risk factors, whether you have an occupational risk factor, whether you are unusually exposed, whether you have a family history which brings you to the doctor so that you can discuss about your risk factor. It is broadly divided into two large subtypes, non-small cell lung cancer and small cell lung cancer. We stage each cancer after diagnosis, and based on the stage, based on the subtype, based on the molecular expression, we individualize treatment or tailor make each treatment, which could include focused radiation, which could include chemotherapy, focused surgery, including VATS or RATS, which is robotic surgery or thoracoscopic surgery, and targeted drugs and immunotherapy. With this, I end my session and give to my next speakers who will talk about localized therapy and systemic therapy. Thanks so much.
Thank you, ma'am, for detailed presentation about what are the risk factors of lung cancer and how to go about if something is picked up, and to come to a conclusion to diagnose what next quiz first session. I would like to read the instructions for the quiz. Each quiz rounds consists of 5 MCQs, and the participants should click on the quiz button on the right corner of the page. And in case it is, when you answer the question and the question goes to the next thing, if it is not displayed, please re-click the quiz button again. And it is an MCQ based question. So option A, B, C, D, you will have a buzzer to click on, choose on which questions. And again, the preference will be given most organizing committee, non-Fortis residents also. And coming on to the quiz, session 1, first question. According to ICMR data, which cancer incidence in India is highest? Lung cancer incidence in India is highest in which state? I repeat, according to the ICMR data, lung cancer incidence in India is highest in which state? Option A, Maharashtra, B, Kerala, C, Mizoram, D, Bangalore. And whoever answers first will give, fastest will be given a first preference. So please be quick to answer. Question 2. Which of the following is the most common site of metastasis in small cell lung cancer at the time of diagnosis? Which of the following is the most common site of metastasis in small cell lung cancer at the time of diagnosis? Option A, liver. B, adrenal glands. C, brain. D, bone. Question 3. Which type of lung cancer is strongly associated, a strong link to asbestos exposure? I repeat, which type of lung cancer is most strongly associated with a link to asbestos exposure? Option A, mesothelioma. Option B, small cell lung cancer. Option C, squamous cell carcinoma. And option C, large cell carcinoma. Question 4. A 62 years old male with a 40 pack year smoking history presents for a routine checkup. He has no symptoms. Based on current guidelines, which screening test is most appropriate for the patient? A 62-year-old male with 40 pack year smoking history presents for a routine checkup. Based on the current guidelines, the most appropriate screening test would be chest X-ray, sputum cytology, low dose CT, and PET CT. Which histological subtype in lung cancer is most commonly associated with central location and cavitation? Which histological subtype of lung cancer is most commonly associated with location in the central of the lung and cavitation? Option A, adenocarcinoma. B, squamous cell carcinoma. C, large cell carcinoma. And D, small cell lung carcinoma. I would like to invite Dr. Sonali Shinde, radiation oncologist, to give a presentation about the management of lung cancer, local management, role of surgery and radiation.
Hello everyone. I'm Dr. Sonali Shinde. Today I'll be talking about role of surgery and radiotherapy in lung cancer. Lung cancer is mainly divided into small cell lung cancer and non-small cell lung cancer. Small cell lung cancer contributes from 10 to 15%, and it is it could be seen early, and it has widespread metastasis and most commonly seen in non-smokers. Whereas non-small scale cell, you have adenocarcinomas, which accounts for 40% of cases, squamous cell carcinomas, which is 25 to 30% cases, and most often it arises from the mucous membrane of the proximal bronchi. Whereas large cell undifferentiated carcinomas, it is rare, and it is rapidly growing tumors often located in peripheral lung tissues. So coming to the staging of lung cancer, the staging of lung cancer, the main, it is according to the TNM staging of the AJCC 8th edition, the AJCC 8th edition, the lung cancer is divided into T1 T1 stage is mainly accounts for tumor less than 3 centimeters, and in which it is minimal invasive, includes minimal invasive adenocarcinoma. T1A, which is less than 1 centimeter. 1B is more than 1 centimeter to less than 2 centimeters, and 1C, which is more than 2 centimeter to less than 3 centimeters. Whereas T2 we can include tumors from T3 to tumors will include T3 to T5, like 5 centimeters, 3 centimeters to 5 centimeters, and involves main bronchus, and regardless of the distance to the carina. And or it can also involve tumors which are invading into the visceral pleura or associated with atelectasis or obstructive pneumonitis. T3 tumors are tumors which are less than 7 centimeters in the greatest dimension, and it directly invades any of the following, any of the this one, this like parietal pleura involvement, or chest wall involvement, phrenic nerve involvement, this one, parietal pericardium involvement, or having a separate tumor nodule in the same lobe. Whereas T4 than 7 centimeters in size and invades any, it can invade the diaphragm, mediastinum, heart, great vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral bodies, or having a separate tumor nodule in the same lung as that of the primary tumor. So as that of the primary tumor. The nodal staging of this one is next slide. The nodal staging, it is again divided into N1, N2, and N3, whereas in N1, metastasis is in the ipsilateral peribronchial or ipsilateral hilar lymph nodes, and it can include involvement by direct extension also. And N2 involves ipsilateral mediastinal and or subcarinal lymph nodes, and N3 will include any contralateral mediastinal, contralateral hilar, or ipsilateral or contralateral scalene or supraclavicular lymph nodes. So the distant mets are staged as M1 and M1A. It is again divided into M1A. M1A can include a separate tumor nodule in the contralateral, in the opposite breast, opposite lung, and tumor with pleura or pericardial nodules or malignant pleural or pericardial effusion. Whereas M1B can have a single extrathoracic metastasis in a single organ, or if it is having a multiple extrathoracic metastasis in a single or multiple organ, it is characterized as M1C. And according to the TNM staging, the 9th edition, there are some changes, whereas the N2, wherein the N2 is divided into N2A, which will include single station nodes, and N2B, which will include multiple stations. And M1C is again divided into, is split into M1C1 and M1C2, whereas M1C1 will have single organ system, and M1C2 will have multiple organ systems. Next slide. The small cell lung cancer is divided into limited stage and extensive stage. The limited stage is a tumor wherein it is confined to one hemithorax. It's confined to one hemithorax. It can include both ipsilateral or contralateral mediastinum and ipsilateral supraclavicular nodes. Whereas extensive stage can include is a tumor which is involving beyond the boundaries of limited disease. It can include distant metastasis, malignant pericardial or pleural effusions involving of contralateral supraclavicular or hilar lymph nodes also. the overview of giving an overview of the treatment options in non-small cell lung cancer. The treatment in stage 1A, usually we perform lobectomy or with mediastinal lymph node sampling. And if the patient is inoperable, then radiation is preferred. In 1B also, it is lobectomy. And if in high-risk patients, we'll be giving chemotherapy as well. And if we are not able to do this like surgery, if the patient is inoperable, then we prefer radiation. In stage 2 lung cancer, surgery followed by adjuvant chemotherapy is the preferred choice. In stage 3, the usual this one is to consider followed by consolidation with immunotherapy. And in stage 4 or recurrent diseases, targeted therapy, immunotherapy, or along with chemotherapy or supportive care along with palliative therapy is used. An overview of the small cell lung cancer treatments. You are in limited stage cancers, concurrent chemoradiation is preferred. And if concurrent chemoradiation is preferred, and if there is a complete response or near complete response is there, then the patients will receive a prophylactic cranial irradiation. If any solitary tumor nodule is there and it is in T1 stage, then surgery can be done. And if there is N0, then chemotherapy alone. And if it is N positive, then concurrent chemoradiation is given. In extensive cases, extensive stage small cell lung cancer, chemotherapy plus is the preferred choice, whereas with or without palliative RT to symptomatic sites. And for patients with partial response, good partial response, or complete response to chemotherapy, prophylactic cranial irradiation can be given. So coming to the surgery in lung cancer, it is stage lesions which can be resectable as stage 1, stage 2, or stage 3A. This one pulmonary function test evaluation should include determination of lung volumes and flow rates, and of diffusing capacity and arterial blood gas analysis. And depending on the patient selection is mandatory. The imaging studies also include the ventilation perfusion studies to determine regional variation in pulmonary function. So what are the types of surgeries which we perform? The radical operation will be pneumonectomy, whereas there are some lung conservation surgeries like lobectomy can be done, and sleeve resection, wherein we are removing a part of the lung and the main airway, that is bronchus. And or wedge resection, segmentectomy, and segmentectomy is usually preferred in cases with tumors less than 2 centimeter, or patients patients having poor pulmonary function tests, and patients where we cannot perform a lobectomy, segmentectomy can be done. Mediastinal lymph node dissection is important here, where it provides complete nodal staging. It helps in identifying patients who require adjuvant radiation, and it improves henceforth it improves survival and improves local control. If mediastinal lymph node dissection is not being done, at least nodal sampling has to be done. So for the primary, what are the way we can perform sublobar resections, that is segmentectomy, or wedge resections, which is done with tumors less than 2 centimeters, and wherein more can be obtained, and or there is a peripheral nodule present, and patient along with this patient is having some poor pulmonary reserve, or major comorbidities are there, and here we have to include mediastinal lymph node sampling of N1 and N2 stations. The separate if separate nodules in the same lobe or same lung is present, then we can do lung parenchyma preserving sleeve lobectomy, which is better than pneumonectomy. And sleeve lobectomy is a dissection in which resection of a portion of lung and main bronchus is done, are removed while preserving the lung function. So in T3 or T4 local invention or extension of the lesion, en bloc resections are done. And if the stage is, if the lung cancer is in having N2 or N3 disease, then no surgery is preferred. So what are the types of lobectomy we follow? We have open or thoracotomy, and after we have video assisted thoracotomy, or radio assisted thoracotomy. And the VATS, which are usually done in high volume centers, wherein it improved early post-op outcomes. And this one, it has reduced the hospital stay to less. The criteria wherein for inoperability, tumor-based criteria, you have cytologically positive effusions are there, vertebral body invasion or encasement of greater vessels, extensive involvement of carina or trachea, a recurrent laryngeal nerve palsy, extensive mediastinal lymph node metastasis, extensive N2 or any N3 disease. In all of these cases, surgery is not preferred. So when in all of these cases, surgery is not preferred, and in inoperable patients, we usually take them up for radiation. And so hence, coming to the radiation part on lung cancer, the main objective for radiation is it is used for definitive treatment alone, or it can be used with chemotherapy also, and it is also given an adjuvant treatment post surgery and in palliative settings in certain stages. The treatment for relief of symptoms when the disease is too loco-regionally advanced, or for control. Treatment in special situations like treatment of superior sulcus tumors, treatment of SVCO, or local palliative treatment. So coming to early stage non-small cell lung cancer, in low surgical risk patients, surgical resection is preferred. In high surgical risk patients, we prefer to do SBRT or sublobar resections. In patients who are medically inoperable, SBRT is the preferred choice, that is stereotactic radiotherapy. The how do we choose a patient? So the indications for this is T1 to T2 lesions with N0, non-small cell lung cancers who are medically inoperable. High surgical risk is there, like patients more than 75 years, poor lung function, or patients who refuse surgery. So in SBRT is not done when the tumor size is more than 5 centimeters. There is a direct invasion of central airway, or interstitial lung disease or COPD. Interstitial lung disease is there. The performance status is poor, or life expectancy is less than 1 year. In all of these situations, the stereotactic radiation is not preferred. And the most commonly used doses for stereotactic radiation is 25 to 34 gray will be given in one single fraction if there is a tumor which is in periphery, or less tumor which is of a size less than 2 centimeters, and it is once more than 1 centimeter away from the chest wall. 45 to 60 gray can be given in 3 fractions if the peripheral tumors are if the tumors are in peripheral, and more than 1 centimeter is away from the chest wall. The other fractionations which can be given are 48 to 50 gray in four fractions, which can be given for patients who are having central or peripheral tumors with 4 to 5 centimeter tumors, and with having less than 1 centimeter from the central chest wall. and 50 to 55 in 5 fractions are given to central tumors, central tumors away from 1 centimeter away from the chest wall. And if there are central tumors, then 60 to 70 gray is given in 8 to 10 fractions. So coming to post-operative radiation, in after surgery, the radiation is preferred in patients who are having margin positive, that is less than 0.5 centimeter margin is there. There is R0 or R1 or R2 resection is there. That is microscopic or macroscopic residual disease is there. Hilar or mediastinal node positivity or mediastinal or chest wall invasion is there. So if it is a negative margin, then 50.4 gray in 5 to 6 weeks is the dose which we use. And if there is an extra nodal extension or positive margin is there, then we have to give a boost to the area, and the total dose will be 54 to 60 gray in 6 fractions. And if there is any gross residual tumor, then again we'll be boosting the gross tumor volume, and the total radiation which we give will be 60 to 70 gray in 6 to 7 weeks. So coming to a conclusion, in the stage 3, if it is resectable, we'll be giving pre-op chemo or chemo radiation followed by surgery. And if any positive, any high-risk features are there, then adjuvant chemo, or if radiation is not given before, then post-op RT is given. And in unresectable cases, we'll be giving, we can give chemo radiation or a radiation alone. So here if we are giving this one, then if in chemo radiation, we can get we can give a dose of 60 to 60 gray in 30 fractions, or or a dose of 45 to 30 gray in a BD, this one in small cell lung cancers, and so dose of small cell lung cancers in limited stage, will be giving a 45 gray to 45 gray in 30 fractions in over 3 weeks, wherein we are giving a BD dose, that is say dose radiation twice a day with a 6 to 8 hours gap in between. Or in elderly patients, we can give a hypofractionated dose of 40 gray in 15 fractions. And the standard dose which we follow is 66 to 70 gray in 33 to 35 fractions is followed for small cell lung cancers, or in even in chemoradiation. So coming to stage 4, in stage 4, mainly radiation part is mostly for palliative setting alone, and it can be given in the thorax, bone, or the brain. And the most common doses which we follow here is 20 gray in 5 fractions, or 30 gray in 10 fractions, or 10 gray in a single fraction. In brain, mostly SBRT can be given if there are limited mets are there, and if multiple metastasis is there, and more than 5 mets are present, and the whole involvement of the whole brain, then we'll be giving whole brain radiation, and boost to the areas wherein the single mets are present. So in bone metastasis, 8 gray in a single fraction can be given along with bisphosphonates. This suggests that for patients with widely metastatic disease and good performance status, an initial trial of chemotherapy should be offered, with radiation reserved for non-responding lesions alone. So radiation should be used early in patients with metastasis to weight-bearing bones, impending spinal cord compression, or caval, or major airway obstructions. So what is coming to the this one, prophylactic cranial irradiation? Prophylactic cranial irradiation is mostly given in small cell lung cancer, and in limited stage, who have responded, who have a good response, that is a complete response or a good partial response is present. And the benefit of PCI is is unclear in patients who have undergone definitive therapy for very early stage of limited stage small cell lung cancer, but in other cases, their patients have a lower risk of developing brain metastasis than patients with more advanced limited stage small cell lung cancer. So herein we have to do a brain MRI surveillance should be performed in patients wherein we are not doing the PCI. And the preferred dose for PCI is to the whole brain. We'll be giving a 25 gray in 10 fractions, which is a daily fractionation. And the standard dose is that, and we can also give a 36 gray in 18 36 gray in 18 fractions, or 24 gray a twice daily fractionation can be given, but it is not found to be superior. So the standard which we may use is 25 gray in 10 fractions alone, and it is not recommended in patients who are having a poor performance status, and it is usually started 2 weeks after the last chemotherapy. And the most common toxicity which can be here is impaired neurocognition. So as coming to SVC syndrome, lung cancer is the most common cause for SVC syndrome, which causes over 80% of cases. The early mortality from SVC syndrome was 2%, and patients can present with cough, dyspnea, dysphagia, swelling or discoloration of the neck, face or upper extremities. Pleural effusions associated in 60% of cases are due to backflow. Acute obstruction can lead to cerebral edema or laryngeal stridor. Here, biopsy is required, and the treatment can include percutaneous stent placement, supportive care, steroids, diuretics, and elevation of the head. Chemotherapy and thoracic radiation is indicated. The most commonly accepted radiation dose here is 3 gray in 10 fractions, at 30 gray in 10 fractions, or we can give 20 gray in 5 fractions, or 2.5 gray per fraction in 15 fractions can be given. So how are we planning a radiation? Well, planning a radiation, the sequences we'll be positioning the patient, then immobilization is there, CT assimilation, then this one target volume delineation, treatment planning, and treatment delivery. So this is how we usually place the patient in our radiation machine, where we can use any this one VAC clock, or we can use a VAC clock, or we can just place the patient, place fiducials, and then take a CT scan. And here in lung cancer, there can be motion. There is something called motion management. When we treat patient with assumption that shape, volume, and relative positions of the structure will remain same throughout the treatment, in reality, the tumor is dynamic. So what are we suppose lung tumors can move randomly in all direction with every breath. So here this leads to a very large. We have to give a very large margin to the tumor, which increases the target volume. So here what we do is, in motion management, there are many motion management strategies which we use in tumor. If tumors are if the tumor motion is more than 5 mm in any direction. So what are the management strategies which we can use is planning with motion unrestrained. We can use imaging techniques like fluoroscopy, slow CT, breath hold CT, or 4D CT techniques. We can use breath holding methods like DIBH, absolute breath control, patient control spirometry, audiovisual feedbacks. We can also use something like abdominal compressions, like forced shallow breathing. Compression plate can be placed on the patient abdomen, or stereotactic body frame can be used. We can nowadays we are using tracking, like external or internal markers are placed, like fiducials are placed, and we track the motion using infrared cameras, and then can assist, and these can be assisted with gating and real-time delivery of the treatment. So gating, this can be a phase-based or amplitude-based gating can be used. External or internal markers are used here, and this all of these can increase as the treatment time for a bit. So attempts must be made to control or mitigate this if respiratory motion amplitude is more than 1 centimeter. And in 4D CT or respiratory control correlated CT, it is used to evaluate the exact movement and to find out the phase of respiratory cycle in which the tumor is to be treated. The console is then made into a movie mode, and we can see the motion of the movement of the tumor lung and the tumor, and depending on this we'll be contouring this one and giving a margin, and it'll include appropriate ITV and PTV margins are given. And see, this is how there is be a reflective marker which is placed, and this infrared sensor and camera will be present, and it'll detect the movement of the chest wall and the abdomen along with the this one of the tumor. So multiple CT images are acquired, and respiratory motion is recorded with by surrogate marker, and the images are converted, are sorted by an algorithm, and then we on depending on the contouring, this one GTV is contoured, and it can lead to multiple GTVs can lead to a ITV, and which will include the all motions over the respiratory cycle. So this is how the GTV is contoured, and then we get a multiple image like a motion cycle. We'll be getting a ITV, and for this we give a margin, and this reduces the tumor volume of the lung cancers. This 4D CT is usually used in patients with tumor less than 4 centimeter and easily moving tumors. And deep inspiration breath hold. Coming to deep inspiration breath hold, this is a breathing instructions are given, like take a deep breath or assisted breath hold by use of valve spirometry, or a spirometer or active breathing coordinator is used. Here beam is turned on during breath hold, and here the most disadvantage is the patient cooperation is required, and it is difficult to use in elderly, frail, or reduced pulmonary reserve patients. So during the treatment beam gets on only when the patient is is having a maximum expiration. This one. Coming to vision RT or SGRT or gate RT, herein ensures the patients are positioned correctly before and during the treatment by tracking skin surface by using non-ionizing and non-invasive camera technology. The markers used are less, and it is a 3D surface tracking. It uses a single stereo camera unit which tracks patients during CT acquisition. This technique facilitates pre-breathing breathing gating of the beam through real-time optical tracking of the respiratory motion. So this is more patient-friendly. And all of these methods are used to make sure that the tumor receives maximum radiation, and the surrounding lung or the heart and the this one spinal cord receives less radiation. Thank you. Request Dr. Shweta to take over for the quiz.
Coming on to the second session quiz, participants, please click on the quiz option in the second, on the right corner of the page. And if questions are not answered, next question doesn't come, please click on the quiz button again before attempting the next question. Coming on to the first quiz of the session, which of the following findings would automatically stage the patient as a stage 4 lung cancer? I repeat, which of the following findings which automatically put the patient as a stage 4 lung cancer? N3 lymph node involvement, malignant pleural effusion, primary tumor more than 7 centimeter, and contralateral mediastinal lymph node metastasis. Question 2. Which of the following is the minimum predicted post-surgery FE force expiratory volume, 1% of the volume required for lobectomy in cancer patients? Which of the following is the minimum predicted post-surgery value of FEV, 1% of the volume required for lobectomy in lung cancer? Less than 20%, more than 40%, 25%, and 60%. Question 3. Which of the following is the major advantage of the stereotactic radiotherapy? Which of the following is the major advantage of stereotactic radiotherapy? Option A, requires multiple daily treatments for months. B, used only for treating metastatic cancer. C, delivers a high dose precisely to the tumor in fewer sessions. And D, causes severe damage to surrounding organs. Question 4. A 70-year-old female with metastatic adenocarcinoma of lung presents with worsening headache, confusion, and projectile vomiting. MRI showed multiple brain metastases with perilesional edema. What is the best palliative treatment? Option A, whole brain radiotherapy. B, surgical resection. C, stereotactic radiosurgery. And D, chemotherapy only. Question, last question of the session. Which surgical procedure is considered the gold standard for lymph node, mediastinal lymph node staging in lung cancer? I repeat, which surgical procedure is considered the gold standard mediastinal lymph node staging in lung cancer? A, endobronchial ultrasound guided transbronchial needle aspiration, EBUS-TBNA, mediastinoscopy, or thoracocentesis, or chest tube placement and draining of the fluid. I like to repeat, the first preference will be given for people who answer the quiz fast. Now I like to invite Dr. Dhyaneshwaran, consultant medical oncologist, to give a detailed presentation about role of systemic therapy in lung cancer.
Good afternoon, everyone. So thank you, Sweta, for your introduction. So I am going to talk about the management of lung cancer from stage 1 to stage 4, which includes small cell carcinoma of lung and non-small cell carcinoma of lung. So before going to the management, how to approach to stage 1 to stage 3 lung cancer. So before starting the therapy, we should know few receptor status like EGFR and ALK fusion and PDL1 status, because these receptor status are important in adjuvant therapy as well as neoadjuvant therapy, particularly immunotherapy. So adjuvant therapy, so post-surgery, when to start adjuvant therapy? From stage 2B onwards, adjuvant therapy required, like chemotherapy plus immunotherapy combination, or only targeted therapy like EGFR positive patients osimertinib and ALK positive patients alectinib. So in stage 1B and 2A patients, particularly high risk features, particularly poor risk, histopathologically poorly differentiated carcinomas required adjuvant therapy. So otherwise, stage 2B onwards, chemotherapy required. So what are the chemotherapy regimens we can use? So platinum-based regimens like cisplatin plus combination with pemetrexed in non-squamous. In squamous, cisplatin plus gemcitabine or cisplatin plus docetaxel we can try. So adjuvant therapy, particularly in ALK positive and EGFR positive. So ALK positive, alectinib 600 milligram twice daily for 2 years we have to give. And EGFR positive patients post surgery, osimertinib 80 milligram per day for 3 years we have to give. So in adjuvant therapy, particularly if tumor size is more than 4 or any lymph node involvement or PD-L1 expression is more than 1%, patient is eligible for immunotherapy combination with chemotherapy. So immunotherapy, there are 2 immunotherapies are available. One is atezolizumab, another one is pembrolizumab. So chemotherapy we can combine with pemetrexed plus carboplatin or pemetrexed plus cisplatin. So neoadjuvant therapy, when to give neoadjuvant therapy? So in case of tumor size is more than 4 centimeter or node positive disease, EGFR and ALK negative, particularly in we are preferring to give immunotherapy with combination of chemotherapy. So what are all the neoadjuvant options? So neoadjuvant immunotherapy plus chemotherapy options. So neoadjuvant, there are 3 immunotherapy approved. One is nivolumab, another is pembrolizumab, another is durvalumab. So nivolumab, it is combined with platinum-based chemotherapy every 3 weeks once, up to 4 cycles. Same pembrolizumab also every 3 weeks once, 4 cycles. 4 cycles followed by maintenance pembrolizumab, pembrolizumab. In case of durvalumab also a combination of chemotherapy plus durvalumab followed by only durvalumab maintenance. Next slide, please. Stop now. Not moving. So neoadjuvant therapy. So in neoadjuvant immunotherapy combination with chemotherapy, there are three drugs are we are using commonly. One is nivolumab, another one is pembrolizumab, another one is durvalumab. So nivolumab combined with platinum-based therapy for every 3 weeks, one for 4 cycles, followed by surgery. In pembrolizumab combined with platinum-based therapy every 3 weeks for 4 cycles, followed by only continuation of pembrolizumab. And durvalumab also same like pembrolizumab combined with the platinum-based therapy and followed by surgery and followed by single agent durvalumab therapy. Only total duration of therapy for pembrolizumab and durvalumab, it is 1 year. So how to manage stage 3? So stage 3, this management is divided into 3 parts based on the mediastinal lymph node involvement. Either mediastinal lymph node involvement is there or no mediastinal lymph node involvement. And clinically stage 2, but pathologically means post-surgery, it is stage 3. So first we will go ahead for no mediastinal involvement. So in this case, stages are T3N1 and T4N02N1. So here the induction chemoimmunotherapy or perioperative immunotherapy. So perioperative means before surgery 4 cycles of chemotherapy. After that followed by maintenance of immunotherapy. It can give in case of no medicinal involvement. So in clinically stage 2, but pathologically stage 3 disease, if patient is completely resected, no positive margin, we can go ahead with the adjuvant chemotherapy. If positive margin it is there, we can give chemoradiotherapy or only radiation therapy. So N2 disease. In N2 disease are divided into two aspects. One is non-dissectable, another is dissectable disease. So in dissectable disease, we can go ahead with the induction therapy followed by surgery and maintenance therapy. So what are all the criteria for induction therapy? So one is in N2 disease, single station involvement, less than 3 centimeter tumor, and disease can be resected via lobectomy, not pneumonectomy. So it's an indication for induction. So if it is not possible to resect, definitive therapy like chemotherapy combination with radiotherapy followed by durvalumab maintenance 1 year. So N3 disease. So N3 disease, there are two options based on the EGFR expression. So one is if it is one is CTRT chemoradiation followed by durvalumab maintenance, or CTRT followed by osimertinib in case of EGFR positive. So concurrent chemotherapy plus radiotherapy. So what are all the drugs can be used along with radiation? One is carboplatin along with pemetrexate or cisplatin pemetrexate. Paclitaxel we can use. Cisplatin etoposide we can use. And paclitaxel in 2 cycles followed by additional 2 cycles, total 6 cycles we can use. So stage 4 lung cancer management. So before going to start the stage 4 lung cancer management, before that we should know the receptor status like EGFR, ALK fusion, RAS, RAF, and MET, HER2, and NTRK receptor status. And important one is PD-L1 expression. So based on that, we can divide a lung cancer treatment or stage 4 cancer into divided into 2 parts. One is targeted therapy targeted mutation positive cancer. Another is targeted mutation negative lung cancer. So first we are going to deal with the targeted gene mutation positive lung cancer. So first one is EGFR mutation. It is very common in Asian population, around 40 to 60%. In Western population, it is 15%. So here it is a common mutation is exon 19 deletion or exon 21 point mutation. So other rare common is EGFR S768I, L8861Q, G719X mutation, but less than 10% only. So few mutations are resistant to first line treatment like osimertinib, particularly exon 20 insertion or particularly exon 20 insertion. So what are the drugs we can use for EGFR mutation positive cases? So drugs divided into first generation, second generation, and third generation. First generation which include erlotinib, gefitinib. Second generation which include afatinib. Third generation which include osimertinib. So in case of patient present with brain metastasis, afferent brain metastasis, we can prefer to give osimertinib because blood-brain barrier penetration is very high in osimertinib compared to first generation and second generation TKS. So ALK fusion. So it is a rearrangement of anaplastic lymphoma kinase gene fusion with the echinoderm microtubule associated protein like 4, ALK EMLA4. The incidence is 2 to 4%. The young, age of onset is young. It is associated with smoking or without smoking also. So it is usually associated with adenocarcinoma. Sometimes it is reported in squamous cell carcinoma, but incidence is less than 1%. Drugs used for ALK rearrangement positive. One is alectinib, brigatinib, ceritinib, crizotinib, and lorlatinib. So commonly we prefer to give lorlatinib as a first line of treatment because lorlatinib has excellent blood-brain barrier penetration effect. So that is why lorlatinib is preferred in ALK positive brain metastasis patient. So RAS1 rearrangement. So incidence is 1 to 2%. So the translocation between RAS1 and other gene, most commonly CD74. It is associated with adenocarcinoma, younger age, and never smokers. So it is highly sensitive to 2 drugs. One is entrectinib and is crizotinib. Because of entrectinib and crizotinib. So among 2, entrectinib is preferred because central nervous system in case of central nervous system metastasis, entrectinib blood-brain barrier penetration is high. BRAF mutation. So BRAF mutation, it's a downstream signaling mediator of KRAS pathway, which include a MAPK pathway. The incidence is 1 to 3%. So associated with the smoker. The common mutation is V600E. Usually combination of MEK inhibitors like defrapenib plus tremelimumab is approved in first line of treatment. NTRK fusion. So it is prevalent in 1%. It can be tested in other cancers. The treatment for NTRK targeted therapy can be used in later line of treatment in any other cancers also. So the common drugs are lalotrectinib, entrectinib. So it can be used in a patient who received multiple lines of treatment, including immunotherapy, or later line of treatment we can use in fit patient. So HER2. So HER2 is it's a EGFR receptor family. So mutation is common compared to amplification. So 1 to 3%. So drugs commonly used are TDXD and TDM1. So MET abnormalities, there are two things. One is mutation, another one is skipping. One is skipping mutation, another is amplification. So it's common in 2 to 4% of the non-small cell carcinoma of lung. The drugs used as crizotinib and cabazitaxel. So other drugs like divided into small molecule inhibitors and antibodies against MET receptors. Another thing is ADC, means antibody drug conjugates. So small molecule inhibitors are like crizotinib, savolitinib, tepotinib, foritinib. So antibodies like onartuzumab, or amivantamab, or antibody drug conjugates like telisotuzumab vedotin. RET amplification, the incidence is 1 to 2%. It's associated with adenocarcinoma of lung. So it never smoke, associated with never smoker, younger patients, and minimal smoking history. So the common prevalent RET mutations are KIF5B, CCDC6. The drugs targeting are two drugs. One is selpercatinib and pralsetinib. So RAS mutation. So RAS mutation found in 25 to 30% of lung adenocarcinoma. So it is frequently observed in Western population compared to Asian population. So most prevalent is G12C. So 45% is associated with the smokers and followed by G12V and G12D. So the drugs are available only for G12C. Other targeted, no drugs are available. The common drugs are sotorasib, adagrasib. So we come to the genomic negative lung cancer. So how we will treat? So based on the immunotherapy markers, so like immunotherapy, if PD-L1 expression like more than 50%, less than 50%, or patient in rapid progressive disease. If it is immunotherapy markers negative patients, how we are going to treat? And in supportive care, particularly in patient like brain metastasis or patient with severe comorbidities, with severe multiple comorbidities, they are physically unfit to take chemotherapy patients, we offer supportive care. So PD-L1 more than 50% expression. So how to treat this patient? There are two options. One is based on the clinical status of the patient. So either a patient present with rapidly progressive disease or absence of rapidly progressive disease. So in case of absence of rapidly progressive disease, PD-L1 more than 50%, we prefer to give single agent immunotherapy, particularly pembrolizumab, 200 milligram, 3 weekly we can give. So the trials compared with the pembrolizumab plus chemotherapy, the PFS OS benefit will be superior compared to chemotherapy. But at the same time, in data showing severe grade 3 toxicity will be high in immunotherapy arm. So pneumonitis reported in 5.8% in lung cancer patient. So another alternative to pembrolizumab, a combination of two immunotherapy like nivolumab plus ipilimumab. So they compared with the chemotherapy, they found a better OS compared to chemotherapy. So in rapidly progressive disease, again PD-L1 more than 50%, we prefer to give pembrolizumab plus chemotherapy. So the PFS response compared to chemotherapy arm, it is superior. But statistically, the OS response is statistically not significant. So another option like in case of PD-L1 less than 50% or PD-L1 expression is unknown. So in this case, combination of chemotherapy plus immunotherapy works well, particularly pembrolizumab plus chemotherapy or atezolizumab plus chemotherapy works well. So chemotherapy means we can combine paclitaxel, pemetrexed plus carboplatin. We can combine with chemotherapy, immunotherapy. So these are all the common regimens we used for PD-L1 expression tumors like pembrolizumab plus carboplatin, pemetrexed, or pembrolizumab cisplatin, pemetrexed in case of PD-L1 expression tumors. So PD-L1 expression tumor, if it is PD-L1 expression tumors are contraindicated, we can give biological therapy like bevacizumab plus chemotherapy. So how to give maintenance therapy? So particularly in stage 4 cancer, after completion of 6 cycles, patient required some kind of therapy. Either a patient received immunotherapy plus chemotherapy, we can combine immunotherapy plus one chemotherapy which was used in 6 cycles of chemotherapy. Particularly in case of we are using an example pemetrexed plus pembrolizumab, we can continue pembrolizumab and pemetrexed at least 2 years. We have to maintenance, we have to give. So next our topic is small cell carcinoma of lung. So small cell carcinoma of lung, as Sonali said, divided into two topics. One is limited, another thing is extensive. So limited is stage 1 to stage 3. There are few exceptions also there in stage 1 to stage 3. In T3 to T4, due to multiple lung nodules that are too extensive or have a tumor or nodal volume that is too large to cover the radiation. So this will not cover in limited stages. It will be covered in extensive stages. So what is extensive stage disease? Stage 4 plus T3 to T4 lesion with multiple nodules or multiple lung nodules. It covers in extensive stage disease. So how to approach this patient? So again, we have to do basic investigation before starting this one, like pulmonary function test, thoracoscopy, PET scan, and bone marrow. If you're suspecting like nucleated RBC in the blood or cytopenias, that time we have to go do bone marrow. So based on this, we can classify again into limited into 2 and extensive disease. So in limited, if it is limited disease, no lymph node involvement, we have to check mediastinal staging also. If it is clinically mediastinal staging involvement, treatment will be little different. So limited stage disease, clinically no mediastinal involvement, but pathologically mediastinal involvement, it is there means the treatment will be like extensive stage disease. But if pathologically, clinically no lymph node involvement, so patient can be undergo lobectomy. So in lobectomy, even in R0 also, patient required surgery. In R1, R2, even in R0 also, patient required systemic therapy. In R1, R2, patient required systemic therapy along with the radiation therapy. So in limited disease, medically inoperable patient means, so we can give systemic therapy plus concurrent radiation therapy. So here, patient with mediastinal involvement, limited stage disease, based on the performance status, we can assess, we can plan the treatment. If it is good performance status patient, systemic therapy along with radiation we can give. If performance status are poor, so in this case, we can individualize the patient based on the patient status. Either systemic therapy plus or minus radiation, we can give either in concurrent or sequential method. Or if the performance status are very poor, best supportive care we can offer. So in extensive disease, so extensive small cell carcinoma of lung, again, it is based on the symptoms, another is involved site. So involved site means a patient can present with superior vena cava syndrome, bone metastasis, spinal cord metastasis, and brain metastasis also. So patient without localized symptoms, without localized symptomatic sites or brain metastasis, good performance status or poor performance status, combination of systemic therapy we can give, either it is immunotherapy plus chemotherapy. If it is very poor performance status, so in this patient best supportive care we can offer. So localized symptoms like SVC, spinal cord symptoms, bone metastasis. So first we have to treat the localized symptoms and followed by systemic therapy like a combination of chemotherapy or immunotherapy can be given. So spinal cord compression. So first we have to fix the spinal cord and followed by radiation and followed by systemic therapy. So in brain metastasis, asymptomatic patients start with systemic therapy followed by radiation. Brain radiation is mandatory. But in between, after every 2 cycles once, we have to do MRI brain to monitor the disease. And symptomatic patients, particularly symptomatic patients, start with brain metastasis, the brain radiation, and followed by systemic therapy. So how to do follow-up? So once the treatment over, if it complete response, in limited disease, again, patient required a durvalumab follow-up and prophylactic cranial irradiation. In extensive disease, patient already received chemotherapy plus immunotherapy, only MRI surveillance is required. In stable disease, again limited disease, a stable disease, but a limited stage, again patient required durvalumab maintenance. Extensive disease, patient required surveillance. If it is progressive disease, further line of treatment should be discussed with patient. So these are the drugs commonly used for small cell carcinoma of lung, like combination of cisplatin, etoposide, and durvalumab we can give. So in patient relapsed, so classified into less than 6 months or more than 6 months. If patient relapsed more than 6 months, we can try same drug what we used previously, like cisplatin plus combination of etoposide, we can try one more time. So other drugs are like lurbinectin and topotecan, irinotecan, we can try. If it is less than 6 months, so prognosis is also poor. In this case, we can try lurbinectin, topotecan, irinotecan, larlatamab, we can try. So other options like nivolumab or pembrolizumab. Thank you.
Coming on to the last session of the quiz. Let's start the last session of the quiz. Question number 1. Molecular tests required in stage 2 lung cancer. Option A, KRAS. Option B, ALK. Option C, TP53. And option D, BRAF. I repeat, molecular tests required in stage 2 lung cancer. KRAS, ALK, TP53, BRAF. Question 2. Which of the following is an immune checkpoint inhibitor used in lung cancer? Which of the following is an immune checkpoint inhibitor used in lung cancer? Option A, crizotinib. Option B, erlotinib. Option C, pembrolizumab. And option D, pemetrexed. Question 3. Treatment option for stage N3 lung cancer. I repeat, treatment option for N3 lung cancer. Option A, chemotherapy. Option B, immunotherapy. Option C, chemoimmunotherapy. And option D, stereotactic radiosurgery. Question 4. A patient with small cell lung cancer presents with proximal muscle weakness that improves with repeated usage. Which paraneoplastic syndrome is most likely associated with this features? Option A, myasthenia gravis. Option B, Lambert-Eaton myasthenic syndrome. Option C, SIADH. Option D, hypercalcemia. Last question of this webinar session. Osimertinib acts on which path? I repeat, osimertinib acts on which of the following receptor? Option A, EGFR. Option B, ALK. Option C, ROS. And option D, VEGF. Coming on to the quiz discussion. First question, according to the ICMR data, lung cancer incidence in India is highest in Aizawl district of Mizoram. It has an incidence of almost 28.3 per 1 lakh population. Which of the following is the most common site of metastasis in a small cell lung cancer at the time of diagnosis? It is brain. In small cell lung cancer patients, 10 to 15% of the patient present with lung metastasis with brain metastasis at time of diagnosis, and 50 to 60% may develop brain metastasis later in the stage. The diagram explain how brain metastasis happens, how the tumor crosses the blood-brain barrier and invades the brain. Which type of lung cancer is most strongly associated to asbestos exposure? It is mesothelioma. Mesothelioma fibers, when inhaled in low doses, causes chronic inflammation. And as you know, chronic inflammation over a repeated period of time will mount an immune response, inflammation, and development of the cancer cells. And asbestos exposure can also cause other type of benign and also malignant conditions. If a patient is exposed to has a strong smoking history, the most recommended screening test will be low dose CT. It is given that when these are the high risk features like smoking history, radon exposure, occupational exposure, family history in the first degree relatives, when a patient has a chronic obstructive pulmonary disease or a lung or pulmonary fibrosis, second-hand smoking history, and any risk factors, then whenever the patient based on the risk more than 50 years and more than 20 pack years, it's an ideal for low dose CT, which is proven that the best screening. It reduces the chance of picking up the lung cancer very early in high risk individuals by more than 50%. Which histological subtype of lung cancer is most commonly associated with central location and cavitation? It's squamous cell carcinoma. This diagram shows each subtype of lung cancers, how it presents, and squamous cell presents mainly in the central center of the lung near the hilum with cavitation and high chance of metastasis. Which of the following would automatically classify as stage 4? It is malignant pleural effusion. As you can see, malignant pleural effusion or pleural nodule will automatically, which is proven by a tapping and analysis of the pleural fluid, came positive for malignant cells, will automatically stage it as metastasis. Which of the following is a minimum predictive post-operative FEV1 required for lobectomy in lung cancer? Is more than 40%. Usually, FEV1 more than 40% and DLC0 more than 40% is an ideal candidate for surgery. Which of the following is an major advantage of a stereotactic body radiotherapy? It delivers a very high dose, precisely, highly conformly to the tumor in a very few sessions, and the treatment time will be from 3 to 8 days. Shorter duration of the time achieves more than 90% of the control of the tumor and less chance of toxicity due to radiation. When a patient presents with a multiple brain metastasis with symptoms, the best palliative option will be whole brain radiotherapy. This diagram shows how the whole brain distribution is compared to a stereotactic distribution. Stereotactic was mainly used only when there is a very less tumor burden in the brain, maybe 3 to 5 lesions, small lesions. Otherwise, whole brain RT is the preferred. Which surgical procedure is gold standard for mediastinal lymph node staging? It is mediastinoscopy. It is a minimally invasive scopy and it is also used for biopsy to prove the involvement of the mediastinal nodes. Molecular test required in stage 2 lung cancer is because it is ALK positive. Now, ALK positive has a better prognosis compared to other molecular testing. So early stage lung cancer is better to go with an ALK rearrangement test and also EGFR mutation test. Which of the following is an immune checkpoint inhibitor in lung cancer? It is pembrolizumab. Pembrolizumab mainly acts on the T cells. That is, whenever this cancer cells has the PDL1, which inactivates the T cells so that the cancer cells evades the immune recognition by our body. This pembrolizumab or Keytruda or any blockers, PD1 and PDL1 blockers, will block the structure so that this immune evasion by the cancer cells can be prevented. Treatment option for an N3 lung cancer will be chemo radiation. N3 is nothing but involvement of the contralateral mediastinal and hilar lymph nodes and involvement of ipsilateral contralateral scalene or supraclavicular nodes. And if it's a loco regionally advanced unresectable T4 or N3 disease, the preferred modality of treatment will be concurrent chemoradiation or a sequential chemoradiation in case along with immunotherapies. A patient with a small cell which who developed a proximal muscle weakness with which will improve with repeated use. The paraneoplastic syndrome is Lambert-Eaton myasthenic syndrome. Mainly small cell lung cancers, majority of the patients will present with paraneoplastic features. And one more common in the small cell is Lambert-Eaton, which is an antibody response against the voltage-gated calcium channels. Patients usually present with muscle weakness, which improves with movement. Osimertinib acts on EGFR pathway. These are certain pathway how EGFR, osimertinib will act on the EGFR, which is a receptor pathway, and prevents the down regulation so that the mitosis and proliferation of the cancer cells is stopped. Thank you everyone for attending this sessions. I would like to thank all the panelists, Dr. Sonali, Dr. Tyaneshwaran, and Dr. Neeti Raizada ma'am, for giving a detailed presentation about the risk factors and the prevalence of cancer, and how to manage about if lung cancer is detected, and proving a point that all lung cancers, even stage 4, is not a deadly disease. It is highly manageable with proper and timely management. The winners of this quiz session will be announced on the next session, which will be about the ABC of CBCs, the all components of CBCs and their disorders, which will be held on March 6th. I would like all the participants to register for the next webinar on ABC of CBC, which is on March 6th. Thank you, everyone.